Dr. Sara Binder, medical lead and consulting psychiatrist at the Psychiatric Adult Service, Foothills Medical Center. She treats adult outpatients who struggle with mood, anxiety, ADHD, and substance abuse. She developed and runs an ADHD medication group and an 8-week cognitive behavioral therapy based ADHD skills group. Okay, you know what you're talking about. So, Dr. Binder, I'm just going to say no more, and please take the floor.
Thank you. Hi, everyone. I can't really see up there because the lights are bright, and my eye decided to bleed on me last night, but I look better in that picture, apparently. Okay, so we're going to do a quick and dirty because actually these are sort of two separate topics combined into one in half an hour. I could talk on these for the next 2 hours, but we don't have that kind of time. So what we're going to look at today is how hormones in women impact ADHD at different life stages. These are my disclosures. Okay, so in the next half hour, we are going to look at how does ADHD present in females, briefly touch upon some common comorbidities, look a bit at the literature on hormones and ADHD and how that sort of shifts through the lifespan, and then how do you sort of treat ADHD during pregnancy and postpartum, and then towards sort of perimenopause, menopause. So we have a lot to cover, and I want to leave time for questions. So what is ADHD? So ADHD is a neurodevelopmental disorder. People are born with it, and it runs in families. So it's highly heritable. It's almost as inheritable as height. So if someone in your family has ADHD, a parent, a sibling, a child, it doesn't usually skip generations. It presents very differently in different people within the same family, but it is important to recognize how heritable it is. It's a misnomer to think that ADHD just affects your school day or your work day. Right? It's in your brain. So it's there 24/7, 7 days a week, 365 days a year. It affects all day, every day, including sleep. So it impacts how we relate to people, the choices we make, the decisions we make, how we drive, how we spend money, how we, self-medicate with substances, which is also quite common in people with ADHD. So we know from decades and decades of research that medications are in fact the primary aspect of treatment. And this is robust data. This is not just, we think meds might help. The meds for ADHD are actually twice as effective as antidepressants. A lot of people get diagnosed with common comorbidities like depression and anxiety and get treated for those, and the ADHD gets missed. But in fact, if you have depression, anxiety, and underlying ADHD, what I tell my patients is it's a bit like having an internal bleed. You can put as many Band-Aids on as you want, that bleed's not gonna stop. ADHD is like that, you're born with it. So unless that's actually treated, taking an antidepressant, taking a mood stabilizer, taking a benzo to treat anxiety is not going to fix the core difficulty. And like I said, this is a condition where we have medications that have been robustly studied in kids extensively before they were even used in adults. They're very safe, they're very effective, and twice as effective as antidepressants. It doesn't go away. So when I was in residency 20 years ago, my teaching was, it's an illness of kids. So adults don't have this. If you weren't diagnosed as a kid, you don't have it. Not true. You don't suddenly blow out the candles on your 18th birthday and poof, your brain miraculously repairs. As parents of kids that age, that would be lovely, but it's not reality, right? So this goes on and it waxes and wanes through a person's life, and it's very context dependent. So if you're in a context where your ADHD is able to thrive and you're able to be naturally interested and stimulated and motivated and have lots of external structure and scaffolding, people will thrive and be exceptionally productive and effective in part because of their ADHD. But at other points in life, when responsibilities overwhelm compensatory strategies, people with ADHD sometimes crash and burn and are very functionally impaired. I see a lot of professionals in my practice who have been very successful to a point. And sometimes on paper, they look really good and they look like they're functioning very well, but internally they're not functioning very well. And the effort they have to put in to succeed is 10 times higher than their peers. So it has a really profound impact on the individual, and the burden of illness is extreme. Not just personally, familially, societally, but the actual financial cost is billions of dollars a year. So these are the symptom criteria that are part of a formal diagnosis. So inattention, hyperactivity, and impulsivity are in the DSM, which was referred to in the last talk. Emotional dysregulation is not a formal symptom cluster, but it affects 90% or more than people with ADHD. Borderline personality disorder was brought up in the last talk. Many young women get misdiagnosed with borderline personality disorder because they're impulsive and emotionally dysregulated. If they're actually assessed for ADHD, many of them actually meet criteria for ADHD, and in fact, we have very good treatment for ADHD. We don't have medications to treat borderline personality disorder. We have dialectical behavioral therapy, which is very effective for both people with ADHD and borderline. But the med piece is what's sort of missing, that core internal bleed, right? So how do these present in kids, adults? It changes markedly. It's kind of that what you see is what you get in kids, right? It's obvious if a kid can't pay attention, like they're not looking at you, they're not responding to questions, they can't follow through with requests, they're forgetting, they're losing, they're misplacing, they're fidgety, they're bouncing off the walls, they're blurting, they're interrupting, they're pushing, they're shoving. Adults tend not to behave quite like that. I mean, Tom Cruise jumping off of a couch, whatever, right? But I mean, mostly you sort of learn some social skills. So you can like make eye contact, nod, say, But the way ADHD works is it comes down to two key neurotransmitters in the brain, which are dopamine and norepinephrine. Those are responsible for executive functioning. What is executive functioning? It is our higher level brain functioning, our ability to think, to plan, to prioritize, to set goals, but also to regulate emotions and control impulses. Dopamine and norepinephrine are critical neurotransmitters for that executive function. Otherwise, you have this reptilian brain that's all reactive to impulses and emotions. We need that extra layer to help regulate and control. So if you have ADHD and you don't have enough dopamine or norepinephrine, or those levels are inconsistent, you'll have this like impulsive, emotional, dysregulated brain, right? So when we treat ADHD, all we're doing is we're stimulating dopamine and norepinephrine so they're at stable levels through the waking hours of the day, which for most human beings should be 16 hours if you sleep for 8. They should not be physically stimulating. They should actually be calming, because an untreated ADHD brain is trying to stimulate dopamine and norepinephrine. So dopamine is our pleasure reward neurotransmitter. So people with untreated ADHD are going to go towards things that stimulate dopamine, right? Pleasure reward. So we see a lot of addictive disorders, not just drugs and alcohol. Sex, porn, gambling, gaming, internet, binge eating are highly common in untreated ADHD. So until we actually treat that by stimulating dopamine, the brain's going to keep seeking it. The norepinephrine is like our adrenaline system. So that leads people to seek stimulation through worries, obsessions, ruminations. So we see high comorbid anxiety in people with untreated ADHD. The stimulants actually calm them down. They don't make them more anxious because, again, that untreated brain is trying to stimulate. The stimulants stabilize the dopamine and norepinephrine so the brain can be calmer and focus on what it actually needs to, rather than seeking out that constant stimulation. So again, adults are good at sort of trying to compensate, find the skills and strategies to nod, But if you actually challenge somebody, like if you're in the audience and what I'm saying is super boring for you, or something in your head or around you is more interesting or stimulating or important, and I asked you a question, you might not be able to respond because that thing was way more interesting. So that can be very socially anxiety provoking, right? If you know that you can't respond in one-on-one, or you can't respond in meetings or in a school setting. The other piece is that no braking mechanism. So people with ADHD have trouble stopping and thinking before saying and doing. And that's that impulsivity. And so that can lead also to a lot of anxiety, because they know that I'm not sure I'm going to be able to sort of control myself in this social setting, and it's embarrassing and people don't want to be around me. So what we see is in untreated ADHD by adulthood, 85% of people will have developed at least one other mental health condition. So people with ADHD are in mental health, they're in family practitioner's office, they're in psychologist offices, often being treated for the comorbidities. The most common are the mood disorders, anxiety disorders, eating disorders, sleep disorders, and substance use disorders. And some of the medications that we treat these patients with actually worsen their ADHD. So SSRIs were brought up as sort of a first-line treatment for PMDD. In fact, in people with ADHD, SSRIs are not the best strategy because they can actually suppress dopamine and norepinephrine over time. So it's important to kind of also know how best to treat the comorbid conditions once you've actually treated the ADHD. Okay, so we see huge differences. Way more boys than girls are referred, diagnosed or way more boys are referred and diagnosed than girls. But by adulthood, it ends up being a 1-to-1. So it really begs the question, what's happening to all these girls that are left undiagnosed and untreated? And really, by adulthood, way more women go to the doctor than men, and so then they start getting diagnosed and they start getting treated. But many of them accumulate those other diagnoses along the way. So here, it's probably fairly self-evident, but the girls tend to be more shy, quiet, inattentive. They tend to struggle more with the executive functioning and self-esteem. And then the boys tend to have more of the sort of outward externalizing behaviors. So the boys tend to have learning disorders, oppositional defiant disorders. So they cause disruption because they're bouncing off the walls or they're pushing, shoving, interrupting, whatever. And so they get brought to the attention of the teacher or the coach or the parent's friend or that kind of thing. And it's postulated this is related to dopamine rise earlier in boys than girls. The girls, again, get diagnosed more with the depression, the anxiety, and the eating disorders. And also, if you're very anxious and have ADHD, you don't want to make a scene. You don't want anybody to call you out and tell you to be quiet or tell you to, pay attention or what have you. And so the anxiety tends to mitigate a lot of the impulsive, emotionally dysregulated, hyperactive behaviors until you get home. So a lot of parents will sort of say, gosh, when my little girl comes home, she's out of control, she's emotionally dysregulated, she's all over the place, but it's not seen in other contexts. And to make an ADHD diagnosis, you have to not just have the symptoms, but they have to be functionally impairing in more than one context. And so in girls, it often takes till they hit puberty and the hormones kick in that they start to kind of have this more outward presentation. By that time, they're starting to struggle a bit more with self-efficacy, more of the sort of mood, anxiety, eating disorder diagnoses. But then they hit puberty and we see those hormonal fluctuations, which were reviewed in the last talk. And that actually leads to a lot more of the impulsive behaviors and a lot more of the emotional dysregulation. And we actually see much higher rates of risk-taking behavior leading to STIs and unplanned pregnancies. So they did a big consensus, experts consensus a few years ago and really highlighted the emotional dysregulation, social problems, vulnerability to bullying, the sexual activity, as well as antisocial behavior, so equal sort of male-female ADHD in the jails, and more underachievement and lower self-esteem. So this is the sort of estrogen-dopamine connection. I think the take-home message is that estrogen and dopamine track quite closely together. And as I've told you, when we treat ADHD, we're treating dopamine and norepinephrine. But if you have dopamine that fluctuates through your menstrual cycle, your response to stimulant medication and your ADHD symptoms are going to vary throughout the cycle. So what we actually see is that generally speaking, women with ADHD do better in that sort of first half of their cycle up to ovulation. And then after ovulation, when we see sort of the dip in estrogen, the dopamine goes quite closely along with it, and a lot of them become destabilized, more emotionally dysregulated, more of the cognitive symptoms, more of the emotional symptoms. So we need to sort of first diagnose and treat the ADHD, get that stabilized with medications, and then use those symptom trackers to tweak the medication so that we can treat the drop in the dopamine. So this has already been reviewed in the last talk, PMDD, quite extensively, but it's interesting to note that in a recent study, they found almost half of females with ADHD actually had a PMDD diagnosis, and that when they were on antidepressants, it was actually associated with worse PMDD symptoms. So women with a PMDD diagnosis are more likely to have ADHD and should definitely be screened for ADHD, because in my experience, once I've treated somebody's ADHD and we've tweaked the dose of their medications to coincide with their PMDD symptoms, it gets way better. So it's actually a simple, quick fix for the women who have ADHD with comorbid underlying potential misdiagnosed PMDD. So what most of us do is increase the dose of stimulant by 1 dose increment during the 5 to 10 days of premenstrual symptoms. You can add in an antidepressant, but like I said, in the ADHD population, the SSRIs aren't usually considered first line. But I always talk to patients about pills and skills. So you can't just give somebody a pill and expect everything to get better. People need to work on skills and strategies to manage their symptoms, whether it's ADHD, depression, anxiety, substance use problems, you name it. And I like the analogy of a table with 4 legs. Every one of those legs needs to be solid, or we've all sat at a table with a wobbly tabletop. You can't give somebody a pill if the legs are wobbly. And so those are sleep, diet, exercise, structure, and routine. And those have to be really bolstered during PMS to make somebody sort of respond well to the medication. Okay, so this just highlights that more men are likely to have substance use disorders than women, but lots of women I see also struggle with substance use disorders or those addictive disorders that I mentioned, whereas the women tend to have more of the mood and anxiety comorbidities. This is very concerning, and this just came out in 2025, and it's looking at the life expectancy of women with ADHD and men with ADHD compared to controls. So women's life expectancy was lower than the controls by almost 9 years, men's lower by almost 7 years, and ADHD women were 8 times more likely to attempt suicide. So this is not an innocuous disorder. This is something that actually needs to be assessed, diagnosed, and treated. So if you're wondering about it, I would encourage you to seek assessment. And, if your GP isn't somebody who will do it, then you need to start looking for other options and advocate that squeaky wheel. So I'm not going to go through this, you can read it, but if you've had recurrent mood and anxiety that hasn't responded to typical antidepressants, you've got the family history, you've struggled with addictions, you're consistently inconsistent, feeling very overwhelmed, and as a female had a PMDD diagnosis or borderline diagnosis or struggle with postpartum depression, you should be screened for ADHD. So we all know baby brain. If we've been pregnant, we've experienced it. If we've been with someone, we've experienced it secondhand. It's a real thing, and it's related to the hormonal fluctuations during pregnancy. And it's been validated in studies that there's worse cognitive functioning, memory, and executive functioning in pregnant women compared to controls. And it's possibly it's related to prolactin levels, either being too high or too low. And they do rise during pregnancy and during breastfeeding. So this is probably part of the struggle. How do we treat during pregnancy? I think that, women with ADHD tend to have this sort of risk of promiscuity right around ovulation when you get this dip in estrogen and dopamine, which can lead to getting pregnant, because it's right at the fertile time of the cycle, right? So if you have an unplanned pregnancy, it's much higher in girls with ADHD than those without, and it's associated with more maternal depressive symptoms, poorer health behaviors, less likely to take care of self during the pregnancy, and it can lead to poorer maternal fetal attachment. So we want to protect against this happening, but if it occurs, we want to support, what's going on during that time. So we see now in my practice way more women with ADHD who are wanting to get pregnant. We don't have really good guidelines. We worry as practitioners about exposure to medications during pregnancy. I think the really positive piece is that stimulants don't appear to be associated with an increased risk of congenital malformations. But every individual needs to weigh risk benefits. So some individuals that I see will do just fine being off meds during pregnancy, and others will really decompensate and be at high risk. So it's if you're somebody who prior to ADHD treatment was getting in accidents, couldn't keep a job or a relationship, couldn't manage finances, was self-medicating with substances, the risk of going off medications during pregnancy far outweighs that of actually being on a medication. So I'm not going to go through all of these data, but basically there is some increased risk, like small increased risk of a baby, being admitted to the NICU or having seizures, but it's a very low relative risk. It's just something you have to be aware of when you're making those decisions. But again, that no increased risk of congenital malformations. This was a very positive kind of study in terms of safety of stimulants during pregnancy. The only area they said we should sort of track is preeclampsia risk, but the other areas of preterm birth, low birth weight, NICU admission did not seem to be a big risk factor for babies of moms or moms who were on meds during pregnancy. But you should obviously be tracked closely by your doctor. So collaborative decision-making with, individual practitioner and significant others. I recommend my patients do a med-free trial to see how they're going to function before they make that decision. Ideally, you stay off meds during first trimester if you can function okay and you're not at risk of decompensating. And then sometimes using meds just like as needed during pregnancy or lower dosages is an option. It's not what we would recommend the rest of the time. Like ADHD meds are like glasses for the brain. You don't pick and choose when you want to see, right? So if you have ADHD, you need to take your meds every day. And same dose every day once you find the right dose for you, and make sure you have meds covering you from wake up to bedtime. So most of our meds don't last that long. Even our long-acting medications don't last that long. So most of my patients need a top-up dose. So if they're on Vyvanse in the morning, they need a smaller dose in the afternoon. If they're on Concerta, same deal. So it's very important that you also kind of get that sorted out with your prescriber and then do that dose adjustment during PMS. Breastfeeding, again, we didn't see high rates of meds that were concerning in breast milk. So again, I kind of talk to my patients about give it a try, see how it goes, see how your babe responds. You might want to feed in the morning, breastfeed in the morning, then take your meds, then maybe pump and dump midday, and then feed again at the end of the day, just kind of trial and error. But there's no risk associated with breastfeeding while on stimulants. The postpartum is the really high risk time because the pills and skills piece, sleep, diet, exercise, structure, routine, like out the window when you have a newborn, right? So women with ADHD who have maybe functioned extremely well to the point in time when they deliver can completely decompensate. And our women's mental health clinic at the Foothills tracks ADHD, depression, anxiety with all patients that they see. The higher and more severe the depression and anxiety, the more likely they are to have underlying ADHD. So it has to be screened in women in the postpartum who are struggling with mood and anxiety symptoms. So having ADHD alone makes it harder to kind of make decisions, organize, manage time, remember things, and that can make it that much harder to kind of manage during pregnancy and postpartum and manage a baby. So there's lots of reasons why it's a high-risk time. This just highlights again, women with a history of depression have a way higher, 21 times increased risk of postpartum depression, and postpartum depression is about 5 times higher in women with ADHD compared to those without. This is very interesting. So women who stopped taking ADHD meds during pregnancy were more likely to experience higher level of depressive symptoms even if they stayed on their antidepressant. Whereas if they stayed on or adjusted their ADHD meds during pregnancy, their depression did not get worse. And that is 100% what I see in my clinical practice. I would way rather a patient stay on their ADHD meds because that's that core again. Like you don't want to stop treating the core problem, right? It's not going to just disappear. Okay, I have 1:50 left. Okay, so you've sort of seen this, I'm sure you will see it in the next talk, but basically for 5 years leading up to actual menopause, we see significant fluctuations in estrogen. So for women who have an ADHD diagnosis, this is very destabilizing. Like, okay, so you got diagnosed, you figure out what meds, you tweak them during PMS, everything was good, and then you hit perimenopause and it's like, oh my God, that's not working anymore because like my cycles are all over the place and my hormones are all over the place. So this is a trickier time to treat ADHD, but I would say really get your hormones stabilized and then your ADHD medications are going to work better. And that's going to be individual, which hormones, what combination, and that's for the next talk to address. But that's what I recommend to my patients. Like, get your hormones sorted so that we can then get your ADHD meds stabilized, because we can't kind of try to like follow this up, down, all over fluctuation of your hormones. But we know there's lots of overlap in symptoms of perimenopause, menopause in terms of cognition and mood with ADHD. And this is sometimes the first time that a woman will present with concerns or queries of ADHD. you need to get assessed. Like, it's never too late. So the International Menopause Society actually commissioned a white paper on cognition, and again, it's just validating that those cognitive domains that change in perimenopause are verbal memory and working memory, and that it's a real thing, and that thankfully a lot of those actually resolve post-menopause. So HRT early and postmenopause is safe for cognition for most women. Estrogen early menopause can also be helpful for cognition, but also decreasing risk of dementia. But even later in postmenopause is found to be safe for most women. Of course, it's individual. You have to discuss it with your prescriber. But we don't really have great literature to guide the specific treatment. And I'm not a hormone expert. I don't prescribe it, but I definitely encourage my patients to be on it. And that birth control question, I find women with ADHD are way more sensitive to hormones, and some of them have destabilized when they started an oral contraceptive or even a hormonal IUD. So if that's a time when people became more dysregulated, more, their ADHD became more problematic, sometimes it's related to the hormones. So again, this is like a time of big transitions in menopause, life transitions related to kids and work and parents, relationship stressors. So it could be the first time a woman comes asking about ADHD. And so it's important to get it assessed and treated. And there are some studies showing that our medications, even for women without a diagnosis of ADHD, can really help treat the cognitive symptoms. And then it's sort of curious, like how many of those women actually had an underlying ADHD that never became so functionally impairing until perimenopause. So to conclude, females with ADHD are really overlooked and often misdiagnosed with the comorbid conditions, and it can cause a lot of functional impairment. And we have to consider where women and men are very different is the hormonal fluctuations that can really affect not only ADHD symptoms, but response to meds. So you have to assess for both and treat both, and titrate or change the dose during the cycle. Stimulants in pregnancy, again, risk-benefit is important. Babies born to those moms should be tracked a bit closer. And then we have to follow it up into perimenopause, menopause, but don't forget pills and skills. Like if patients come to me wanting to pop a pill and think that's gonna make everything better, they're not gonna like me very much, because I, from day one, am like, get your sleep on track, cut out the caffeine, eat well, exercise, structure and routine. And that's what makes people overall function better and feel better about themselves. All right, stay tuned.
Come on over, because we've got questions.
Is it all the way over here? Yeah, sure. Okay.
Sure. All right, let's get right to it, because we're limited in the questions here. Up at the top.
Thank you. The various comorbidities and the medications for, SSRIs being the opposite of helpful, and stuff like that. And so for those of us who might have been diagnosed with multiple things, or have done these treatments in various orders and stuff, how would you suggest that we start that conversation with our doctors, saying like, okay, I didn't know these things were related, or I am on this and this and this.
Are you using Band-Aids rather than treating the symptom?
How do you start that conversation saying, hey, how do we get back down to basics and start from scratch?
Yeah, it's a really good question, and I don't know if there's like one simple answer, because it really depends on the practitioner. So I find, because I see obviously lots of patients who have been treated in the community, there's huge variability in terms of people's knowledge and awareness of ADHD and the comorbidity and which treatments work. I think you have to be prepared to advocate for yourself and sometimes be the squeaky wheel. And if you've tried and not getting a good response, I think then you need to seek alternate caregiver, which I get is very hard. It's hard to find a family doctor. Access Mental Health is a great resource to connect with and ask for referrals for, coverage of adult ADHD assessment or mental health assessments. But I think getting as much knowledge and awareness as you can and bringing that forward in a way that's sort of, I've looked into this and I'm concerned about this, and, I've recently learned SSRIs are maybe not the best treatment for mood and anxiety because I also have ADHD. Is it possible to try a different molecule? I've also, I've learned that maybe my symptoms are worsening mid to late cycle because I need to adjust my medications. I think all you can do is ask the questions, and if they're not received well, then ultimately sometimes people need to seek alternate caregivers, unfortunately.
But go in with your ducks in a row, right? Like, go in with some information. Yeah, go ahead. In the pink? Are you wearing pink?
Yes.
Oh, yeah, she's coming.
Thank you so much for the great talk, and I love pills and skills.
Yeah.
So you talked in your talk, you talked about executive functioning. So let's talk about skills and executive functioning. What are the best opportunities for, let's say, a parent to nudge a child who's a young adult and getting the support that's needed to help with the executive functioning skills?
So, lots of people want to do the skills part without the pills part. People will do better, obviously, with the pills on board because it's easier to learn and practice and engage in the skills. I think you have to have a willing participant. Like, that's just reality, right? You can only bring a horse to water, so to speak. So I think if a person's interested in willing, then there are certainly resources out there. I'm not a child adolescent psychiatrist, so I don't have my finger upon all of those. But Can Learn, for instance, is a private not-for-profit in the community that offers supports and groups and such for all age groups. I helped start their adult group like 15 years ago, and it's still running. Have like ADHD coaches can be an option, or psychologists or therapists who have an ADHD lens. That's what I always sort of say. You don't want to just go see any therapist if they don't get ADHD, because it is a very specific lens and you have to understand it. And there are some real basics around the skill piece that can be very helpful, that for people without ADHD do seem very much second nature. But then when you work with someone with ADHD, they've never really thought about, I need to put things in a planner, and I need to set reminders, and I need to actually check it regularly. I can't expect my brain to remember all of this, and I need to break things down into small chunks, and I need to take breaks, and I need to, not have everything at the last minute and expect myself to accomplish it. I need to sort of do some planning ahead. I need to develop bedtime routines and morning routines. If I'm not getting enough sleep deprivation symptoms overlap almost entirely with ADHD. So if you're not getting good 8 hours of sleep with restorative brain function, memory consolidation, emotion regulation, pills are not going to work. So it's a lot of very basic stuff, and I find external accountability is often the key for people. So working with someone where you're setting small goals and then you're returning and you're accountable to somebody else really helps people. And having rules. I find people, I'm just not motivated, or I really want to do this, or I hope I can do this. My patients have taught me that is not enough. You actually have to be diligent and disciplined and have rules for yourself and follow those rules, and then they start to become good habits.
Thank you so much. I always think it's better to come from someone else than mom.
Right?
So I appreciate that. Thank you.
Right? Excellent. Why don't you just keep going down, and why don't you make your way down? Go ahead, go down right there, and why don't you make your way down? We've got a few folks here.
Hi.
Hi.
Just wondering about micronized progesterone is often prescribed for perimenopausal women to help with mood and sleep, and you'll see it prescribed cyclically. And now I've been seeing more about it not working the same for people with ADHD. Are you finding that?
I can't actually say that I have enough sort of experience with specific molecules to say whether they work well or not. I find it's very individual. Dr. Premji, who's next, that's her area of expertise. So I think it would be, but I do know I heard her yesterday at our other conference, and I don't think there is a ton of evidence for progesterone specifically for sleep and mood. I think it's about stability, right? So it's about having your hormones stabilized and your ADHD meds stabilized. And in my experience, once you find the right drug and you find the right dose, there's not evidence of people developing what we call tachyphylaxis, where you stop getting a response to ADHD meds and need a higher dose. It's because the skill piece has fallen off the mark. So if you find the right meds and then suddenly, oh, my meds aren't working anymore, it's usually because the sleep is disrupted, they've stopped exercising, they're like stressed out, they're not eating enough, no structure routine, right? So that's taking it to another level, but I would ask Dr. Premji that question, yeah.
Boy, that's an excellent question. Go ahead.
I've been told I have ADHD. My doctor said, no, you don't. I got a psychiatrist who said I did, but I've been told for 30 years, depression. So SSRIs, SRNIs. But now lately I'm finding that like you were saying before, I'll blurt out something that I've been able to suppress for all these years, like, shut up, or, and my husband's like, you're gonna get me killed, right? And so now, like, I'm still on Wellbutrin and stuff and coming off the other ones, but I had the psychiatrist who first diagnosed me about 5 years ago at the Rocky View said, I would prefer that you come off of those before we start treating you with ADHD medications.
So I do it in the opposite. So lots of people come to me on the antidepressants, and unless it's a high dose SSRI, I might start reducing it to see if we can free up some dopamine and norepinephrine, and that people might feel a bit lighter, less like flattened, a bit more energy, concentration better, and make sure the mood and anxiety don't worsen. But I often start treating the ADHD and the sleep from the get-go. And then that's kind of protective, right? Because if we're actually getting at the root cause, it's a lot easier to get people off those Band-Aids. That's not to say some people need SSRIs. I'm not saying they're a bad drug. They work very well for some people. It's just with the specific ADHD combination over time with the suppression of dopamine and norepinephrine, it can sometimes be counterproductive. Somebody said Cymbalta. SNRIs, so that's duloxetine or Cymbalta. I don't like Effexor because it's the worst drug to get off of. Yeah, vortioxetine or Trintellix is another one. So there's some that just people with ADHD do better on, but I take the approach of let's treat your ADHD, get that managed, and then see if we can get you off these other drugs.
Because things can be easier to deal with once you've got that. Okay, you've given us a lot of information, and we could go for 17 more hours because we clearly are all impacted by this one. So thank you very much.
Thank you.
That was fabulous, fantastic. Dr. Sara Binder.